Welcome, everyone. As Steve is pulling up his slides, I'll do a quick introduction. Welcome to the last workshop of the day for day one. My name is Gabriella. I'm from AECP, and I'll be moderating this session. But first, a few housekeeping items. So although you'll be muted throughout the entirety of the webinar, please feel free to ask questions in the Q&A window throughout the session, and we'll try to save some time at the end to address those questions. If there are any questions that we can't answer, um, our speakers should be available in their booths during the expo hours, which are 5 to 7 p.m. Eastern time. So we highly encourage you to stop by their virtual booth at that time. And lastly, this presentation will be recorded and available immediately afterward in the Sessions tab. So with that, I'll turn it over to our speaker to get started.
All right, thank you. Can you hear me? Yes, okay, good. So welcome. Thanks for joining for this particular session. So my session is called Beyond the Counter, How Pharmacist Roles Are Expanding to Meet Primary Care Needs. And it's kind of become a little hobby of mine this in the last 6 months or so to really sort of advocate for pharmacists meeting some of these needs. I just want to very quickly highlight something about me that people usually don't know until they get to pharmacy school with me is that I always put way more thought into the title slide photos than maybe I should. And so this particular photo is a photo of the two mobile clinics that Ohio Northern University operates as a way of trying to meet the primary care needs of our medically underserved communities. So to jump into it, and this is like my disclaimer. So a note, this presentation is heavily primary care focused, but primary care is not the only beyond the counter role out there. There's plenty, and by beyond the counter, I mean beyond a dispensing only role. So there's hospital jobs, there's industry jobs, there's government and regulatory, there's any number of medical specialties that you can think of. And I put in the parenthetical like infectious diseases, which is actually my area. I'm not actually a primary care person. My specialty area is infectious disease. And so that's something that you can do with this, as well as academia. That also encompasses me. So there are lots of sort of beyond the counter things that a person can do with a pharmacy degree that aren't just primary care. So a little bit of background. So the system of getting people access to primary care is under a lot of pressure. So I pulled a map here and some numbers and some statistics to sort of illustrate the point. That 100 million Americans lack adequate access to primary care. By primary care, I mean the physician you go to see on a regular basis to address standard everyday medical issues that are affecting your life. So non-specialist physicians, or maybe it's a nurse practitioner, or maybe it's a PA, a physician assistant. So that's what I mean by primary care, and 100 million Americans lack access to that. There is a well-known projected shortage of about 68,000 primary care physicians. It's expected within the next decade. The map is showing you places in which there is a partial or complete primary care shortage. The darker the county that is highlighted, the worse the primary care shortage is. And so, if you look at this map, I'm well familiar with it. I don't know if you can see my arrow, but ONU is right here in this little dark spot. In Northwest Ohio, we have a well-known primary care shortage in this area. And my proposition to you is that so there are a lot of reasons why this is happening, but pharmacists, I think, are very well positioned to relieve some of the pressure on this system that is definitely under a lot of pressure. So this next one is an illustration of how maybe pharmacists can do that. So 90% of Americans live within 5 miles of a pharmacy. And that is encompassed by tens of thousands of pharmacy locations worldwide, more than many other major retail chains. The longer you spend with pharmacy people, the more likely you are to hear the next bullet, which is pharmacists are the most accessible healthcare professionals in the US. We love to say that. but there's a reason to it. It's not just bluster. Like we are, in fact, almost everywhere, and there aren't very many healthcare professionals that you can just walk up to and start talking. And so this map, which you're looking at, the more blue and yellow, the more the population lives within 5 miles of a community pharmacy. So you can see that there's a lot more blue and yellow here, indicating that most people live within that 5 mile area. And some of the more remote and rural counties in the middle part of the country maybe have some access issues, but honestly, not a whole lot of people live there. So a little bit of historical context to what I'm talking about. And the first thing is that pharmacists didn't always do this. But this means a lot of things. Pharmacists didn't always attempt to meet primary care needs. Pharmacists didn't always talk to patients. So for the vast majority of pharmacy's history, pharmacy was dispensing and doing drug interaction checks and maybe preparing a product. Even the act of speaking to a patient, which we would call counseling. Counseling is newer than you might expect. So there was, in 1952, the 1952 Code of Ethics for Pharmacists explicitly said that pharmacists were not allowed to discuss the therapeutic effects or composition of a prescription with a patient. It was unethical for a pharmacist to speak to a patient about something as basic as what this is and what you can expect for it to do. And up until the late 1960s, it was not considered ethical for a pharmacist to label medication vials with a drug name or discuss side effects with a patient. Your job as a pharmacist in that era was to dispense and not say anything else. That was considered the physician territory. You were not supposed to talk about it. And I remember in pharmacy school having faculty members who would talk about this era, like the 1960s. You weren't even supposed to talk to patients. So patient counseling, talking to patients about their prescriptions, became mandated in 1990. And we've seen clinical roles expanding, really accelerating through the 1990s and the 2000s, largely through collaborative practice agreements. Some things are beyond the scope of what a collaborative practice agreement is. Collaborative practice agreements, by the way, are legal arrangements in which a pharmacist will do a service, and they're doing it in conjunction with somebody like a physician. And so you're sort of using some of their authority to perform some of these services. Each expansion that pharmacists have done have required evidence, extensive evidence, advocacy, and time. So my proof of concept for this expansion of pharmacist services is vaccines. So the world that we live in today, pharmacists give vaccines in all 50 states. We're one of the primary places that people go to get vaccines, but that was not always the case. Idaho was the first state that authorized pharmacist immunizations in 1994. And by 2011, all 50 states had followed. So again, a little background context. When I went to pharmacy school 25 years ago, I was first licensed in 2003 in the state of Indiana. And we did not do immunizations. This wasn't part of the curriculum. And I am now an immunization trainer. So you can see how like the profession has evolved over time. I would also suggest that the COVID-19 pandemic really demonstrated that pharmacists have the capacity to do this at national scale. Pharmacists administered hundreds of millions of vaccines during the COVID pandemic at a scale that would have been difficult to do by any other healthcare profession. We improved coverage, especially in underserved communities. We briefly had a period of time with expanded authority where pharmacists administered vaccines to even much younger children than are typically allowed by state laws. And to me, this is the template. You take an idea and then you demonstrate that it's safe and that it improves access, and then you expand. So vaccines started in 1994. The profession showed that they were safe and that they were effective, and then they expanded slowly over time to cover all 50 states. And so that is the template. Most pharmacist clinical services will follow a similar path. You find a need that exists for patient care. You demonstrate that pharmacists have the training and capacity to meet that need. You generate outcomes data, very frequently a lot of outcomes data, then you advocate for policy change, you normalize the service, and you repeat. So vaccines are, again, a perfect example. Um, in the 1990s, no one would ever imagine going to a pharmacy for a vaccine. Now it is entirely normalized. And so that is how this kind of works. So I want to move into some services that pharmacists perform now. And my first one is managing chronic disease states. And the two I'm highlighting here are high blood pressure and diabetes. So high blood pressure, that's hypertension, affects about 1 in 3 US adults, and only about half of the people who have it have this controlled. And the outcomes for having high blood pressure are many and bad, things like strokes and cardiovascular disease. So controlling high blood pressure is a really big, important thing that a healthcare system can try and do. And what do you know? Pharmacist managed hypertension programs show significant reductions in blood pressure versus usual care. And in this context, usual care will typically mean physician only care or care provided by a team that does not actively include a pharmacist who's monitoring the blood pressure and making adjustments to the medication regimen. Keep in mind that both of these disease states are medically managed diseases. They're diseases that we manage with drugs and that require titration of drugs in order to get the best effects. And these are right in the wheelhouse of a pharmacist. The next one is diabetes. Diabetes affects 12% of the US population. Over 115 million adults have pre-diabetes. So this is another big deal disease state. It's another medication intensive disease state that requires medication therapy that is titrated to effect, and pharmacists do that. Pharmacists initiate and titrate insulin, oral agents, and other injectables like GLP-1s, which you probably have heard lots about over the past 5 years, as well as provide patient education. And the evidence is there for this kind of service too. If you look at how services that use pharmacists, they show better A1C outcomes. A1C is a measure of blood sugar over a long period of time. And what you find is that the services that involved pharmacists achieved better control of blood sugar, which is the main metric in diabetes, over time. This is not something that pharmacists do independently right now. All of these things are under those collaborative practice agreements. So in clinics that have physicians and pharmacists that work in them. But there are lots and lots and lots of pharmacists that do this right now for their job, that manage these disease states and make a big difference in the primary care of patients. So I've got another, this is a scenario. So this spring, I wrote an editorial in the Columbus Dispatch, and this was advocating for a new authority that pharmacists might get, which is commonly known as test and treat. So this is a scenario that I wrote about in my article in the Dispatch. So imagine it's 5 p.m. on a Thursday and you're getting sicker by the hour, sore throat, body aches, fever, and the physician's office closed at 4:30. And the next available appointment might be days away. We've already established in an earlier slide that it is hard to get access to primary care. So what are your options? You could go to urgent care, but it's a 20-minute drive and you're going to sit in the waiting room for hours and you're probably going to pay, $150 out of pocket at least on a high deductible plan, which a lot of people have. Meanwhile, your local pharmacy is 5 minutes away and they're open until 9 p.m. And the idea is that a pharmacist could test you for flu or strep in minutes using standard tests that are available for really anybody to use. And if appropriate, could start treatment right away. And this is widely known as test to treat. And so what it is point of care testing for common respiratory infections. So that person in my previous slide, they feel sick, they come into the pharmacy, they describe their symptoms. If it were me and I'm the infectious disease guy, I would probably be testing them for flu and COVID, influenza and COVID-19. Those tests are easy to do. It's called a CLIA waived, which means that you don't need to be working in a actual laboratory setting in order to operate these tests. Most of us have some experience with COVID tests that are CLIA waived. It's that same kind of test. And in a dozen states right now, pharmacists can test you for these things. They can assess the results of that test, and then they can prescribe medications if they're appropriate, all at the same time. And those are the states in the dark purple, by the way, that have independent test and treat authority. And I wrote the article in the Columbus Dispatch because Ohio is considering having test and treat authority as well. What is the evidence? Well, comparable diagnostic accuracy. We're using the same tests that they're going to use in the urgent care clinic or the emergency room or the physician office. Patients tend to be very satisfied with it. You get reduced patient burden. You don't have to drive 20 minutes and sit in the waiting room at the urgent care clinic for hours. And it relieves pressure on other parts of the healthcare system that are stressed, like emergency departments and urgent care clinics and primary care offices. And it is likely that more states will add this authority over time. Another one, hormonal contraception. So 35 states plus DC now allow pharmacists to prescribe self-administered hormonal contraception to patients. You come in and you can ask for it, and a pharmacist can evaluate you and prescribe it to you. And this covers oral contraceptives, patches, the ring, the injection, and there's good data to support that this is a useful service. And so this is something that a lot of pharmacists can do in an awful lot of places right now. There's also, and this is an OTC thing, so you don't actually have to be in one of the 35 states plus DC. The FDA approved an over-the-counter daily hormonal contraceptive, which pharmacists can now advise patients on and counsel them on with no prescription required. This one is a kind of a personal baby of mine. So PrEP is pre-exposure prophylaxis, and essentially what it is a drug that a patient will take every day, or potentially they'll get injected with, and maybe once every 6 months. And it reduces the risk of acquiring HIV by up to 99% when it's taken as prescribed, which, by the way, should strike you as remarkable. Now, that's a 99% possibility of keeping somebody from getting a potentially deadly disease. And so PrEP has been widely available since 2012, but it hasn't seen the amount of uptake that, in my opinion, it should have. Only about a third of eligible Americans are currently on PrEP, with access, awareness, and stigma all contributing to that gap. So access is, can I get to a person who's willing to prescribe PrEP? Awareness is, do I know that this is even a thing that has up to 99% effectiveness? And stigma, of course, I think that's obvious. HIV remains a stigmatized disease, which I don't think it should be, but it does remain that way. How can pharmacists help with this? I think we can help with all three, but especially access. So you think about where all those people who are within 5 miles of a community pharmacy. There are multiple different PrEP options, including an oral daily pill and an injectable twice yearly that is available. Pharmacist-initiated PrEP has a solid evidence base for safety and efficacy. It is legally authorized in more than a dozen states, meaning that in a state where it's legal, a person can walk into a pharmacy and say, I would like to start taking HIV prophylaxis, and a pharmacist can evaluate them and potentially initiate them on something that can reduce their risk of getting HIV by nearly 100%. And they can do it all in that one location. So community pharmacy, I would argue, is uniquely positioned to reach the most people for a service like this. So there are challenges. There are challenges that the profession is working on. One of the big ones is reimbursement, which is the fancy way of saying, can we get paid to do this? And the answer is, it's complicated for a lot of these things. So, for example, I'll borrow the example of PrEP because it's kind of my favorite one to talk about. I'm the infectious disease guy after all. Can a pharmacist get reimbursed for a PrEP service? I mean, it depends on where. But for example, in the state of Ohio, we can get reimbursed for PrEP services through a couple of different routes. But one of them being there's a program called PAPI, and it pays for HIV pre-exposure prophylaxis and people making 500% the poverty level, which is a lot of people. And pharmacists can be prescribers for that or providers for that. So, but it's not always straightforward and clear cut how you get paid for some of these things. So that's a horizon for future advocacy. The second one I hope is obvious at this point: state law related differences in scope. I mean, I showed you multiple patchwork maps. Some states have certain authority that people in other states don't have. In Ohio, I do not have the authority right now to do test and treat until and unless they pass Senate Bill 230, which they're working on in Ohio. Same deal with PrEP. I can't initiate PrEP in Ohio, but I could in another state. And so there's these state law differences in scope. The last one is workflow and staffing. And that has to do with how many people are actually working in places like the community pharmacies, where I would suggest that a lot of this should happen. You really need to see more people working in those places, which to me is a reason to be kind of bullish and positive about the future of pharmacy, because I think this is where the profession needs to go. Okay, I'm going to come around to a little bit of a conclusion before I'll open it up to anyone who has questions. And I'm assuming that I'm speaking to people who are considering pharmacy school. So you will graduate into a different profession than the one that exists today. If you are thinking about pharmacy school today, you should be thinking about what is this going to look like for 30 or 40 years. And to me, at least based on the historical precedents, the trajectory is clear. We've gone from a profession whose job was to sit and dispense and shut up and don't say anything to patients, to a world in which we are providing a myriad of clinical services to people. Many pharmacists don't dispense at all. They work in these clinical roles. So the trajectory is towards more authority, more autonomy, and more patient impact. There are next frontiers. So, for example, the next frontier that is sort of a horizon sort of goal would be independent standard of care prescribing for conditions that don't require a new diagnosis. What does that mean? That means somebody who has diabetes, and we know they have diabetes because they've already seen a physician or a nurse practitioner or a PA. Instead of working under a collaborative practice agreement, pharmacists would simply have standard of care prescribing authority to modify therapy in these patients according to the evidence that exists out there. So that's a horizon that could potentially come with enough advocacy. Another one is behavioral and addiction medicine. Pharmacists are increasingly recognized in policy discussions as it relates to training pathways for opioid use disorder care. So the students who are choosing pharmacy today, you are choosing to be part of that evolution. And this is my last little pitch, like why pharmacy, why now? A PharmD is a clinical doctorate. It is not a dispensing credential. What pharmacy school is training people to manage complex patients and disease states, especially medication intensive complex disease states. That's what you actually learn to do in pharmacy school. And there is a well-known primary care crisis in the US. The shortage is not going to solve itself. That means there is an urgent need for the skills that pharmacists have, like managing disease states with medications, which is what you learn to do in pharmacy schools. And I'm here to tell you, I've been around the block. I'm in my 5th college of pharmacy at this point, either as a student, a resident, a fellow, or a faculty member. Pharmacy school curricula are specifically designed to train you for exactly these roles, and hopefully to make you able to perform the roles that we don't even know will exist yet. And so that's the end of my talk. So the photo, the goofy guy standing in the middle, that's me. And that is me with the very first little cohort of people who entered ONU's 4-year pathway and graduated. They graduated last spring. They're all off doing cool things right now. And the other thing on the other side of the screen, that QR code, you can, if you want, if you found this informative or interesting or entertaining in any way, I wrote an article called "Stop Pretending Pharmacists Can't Meet Primary Care Needs." It was in Health Affairs in January. It kind of went a little pharmacy viral. So if you're interested in reading that, the link in the QR code will take you to that. And with that, if anybody has any questions, I would be happy to take them.
We have one question so far in the chat, and if anyone else has questions, I encourage you to type them in the Q&A feature. Someone asked, why is there a shortage of pharmacists around the area? Wouldn't a pharmacy school placed within a shortage area result in more open jobs for pharmacists?
That's a good question. The shortage is actually not of pharmacists in our area. The shortage is of physicians and nurse practitioners and PAs, like those people that people traditionally think of as providing primary care. All of those dark counties in that map earlier are places in which it's not that there's a pharmacist shortage in those places, it's that there's a shortage of physicians or nurse practitioners or physician assistants to provide primary care, the regular family doctor that people go see. So that's really what the shortage is.
Great, thanks for answering that. I'm not seeing any other questions right now. I'll give it a few more seconds in case somebody wants to type in another question.
Sure.
As a reminder to everybody, if you do have last minute questions that come up after we conclude today's session, you can visit Steve's booth during the expo hours of 5 to 7 p.m. Eastern. And our recordings will be available under the sessions tab on Zoom events. Hearing no other questions, I guess we'll wrap up today. Thank you so much for your time, for your presentation, and for everybody attending. And tomorrow we'll also be having virtual fair with different exhibitors and speakers. So looking forward to seeing everybody there tomorrow, and have a good rest of your day.